It now gives me great pleasure to introduce to you our next speaker, Dr. Doyen Nguyen. She is both a medical doctor and a doctor of sacred theology, and she is a lay Dominican, an academic hematologist, and a moral theologian focusing on Catholic bioethics. She's a graduate of Temple University Medical School, currently teaches at the Pontifical University of St. Thomas Aquinas in Rome, and among her many publications is the book we already mentioned earlier, the 600-page monograph called, and I quote, "The New Definitions of Death for Organ Donation, a Multidisciplinary Analysis from the Perspective of Christian Ethics," published in April 2018, available here at a 30% discount for €80 outside on the table there. Dr. Nguyen.
Yeah. My talk will be a little bit different. I'm a very academic-oriented, and so it will be very academic. Please do not worry about these slides, because if you come to the JHLF website, you're supposed to be able to download the PDF of these slides. Yeah? So kind of concentrate more on the talk. The other thing is, when you go onto the JH website, you will find a menu that is called BD Conference, Brain Death Conference. There would be two types of documents. The kind of the published articles, okay, for instance, brain death, organ donation, and presumed consent, in which you get a little bit more detail, all right, or other kind of material. Also, you have unpublished material, for instance, the birth and development of brain death, as well as the PDF of these slides. Yeah. So the material that I'm presenting here comes from the book, obviously. We have two paradigm shifts. Thus far, you have heard about the first paradigm shift. The first one started in 1968, the Harvard, and the second one come in 1993. At first, it's called non-heart beating donation, and then after that, it has a name called donation after controlled cardiac death, with the acronym DCD. Now, the common point of these two paradigms is that it's created for the pragmatic needs of organ transplantation, and it's implemented without any prior scientific validation. You know, you see, in clinical practice, before you introduce anything, before you introduce a drug, before you introduce a medical kind of testing, you have to run it through animal studies, then you have to run it through small clinical studies before you introduce it into the clinical practice. Brain death did not have any validating studies, nor is controlled cardiac circulatory death. Now, before I start, let's go on with the terminologies, right? I already told you, because during this session we have to deal with quite a bit of alphabet soup, okay? The first alphabet soup, non-heart beating donor. Second one is DCD. At the first, the C in the DCD stand for cardiac, right? But then in 2008, there was this, let's call it the BOUCEK, B-O-U-C-E-K incident, which I will talk about later. And the C suddenly becomes circulatory. However, you know very well that for the blood to run around the body, you need the heart as a pump. So the cardiac and the circulation actually works together, okay? It works as a unit. The heart, in order to work, requires the blood. Every organ in the body requires the blood. But the blood, in order to get to every organ, including the heart, requires the heart to pump, right? So my terminology is CCCD. Now, when they introduced the CCCD, they basically take advantage of the first part of the Uniform Determination of the Death Act, of the UDDA, all right? And the UDDA say that a person, if they have an irreversible cessation of circulatory respiratory functions, they're dead. Or if irreversible cessation of all functions of the entire brain, then that person is dead. So it looks like you have two definitions of death. And the CCCD take advantage of the first one. Now, when you and I talk about irreversible cessation of circulatory and respiratory functions, we tend to think about what with the traditional death, the common sense, the regular sense of death. Well, what is the reason for this CCCD? The Pittsburgh Protocol was very, very honest. Just go out and say, because of the pressing need for organ. Whereas the Harvard Protocol was not so honest. The Harvard Protocol, if you open the first paragraph of the Harvard Protocol, I'll read it for you. It will tell you, our primary purpose is to define irreversible coma as a new criterion for death, and there are two reasons for this definition, okay? One is because of improvement in resuscitative and supportive measures. And the other one is the burden is too great on the patients who suffer permanent loss of intellect, the burden on their families, the burden on the hospital, and on those in need of hospital beds already occupied by these comatose patients. So, you know, they never say, the Harvard criteria never say, well, you know, we introduced this because of organ transplantation. You know, you may have heard from Dr. Zabiga this morning about the birth of the brain death, in which you get all of these preparation work leading up to brain death, in which is actually point out that organ donation is behind it all. But the Pittsburgh Protocol is, the people are very, very, the scientists, the medical scientists, the Vita is one of them. I gave the name there, okay? Very honest. Just say we need organs. And so in order, you know, we need organs, we can go back and do the harvesting from cardiac death. Except that this time we are going to tweak it a little bit. Yeah, we're not just the old traditional cardiac death. That's passé. Let's tweak it. Innovatively reformulated in such a way as to ensure the maximum viability of transplanted organs. So how are we going to do it? All right, but before, so now I talk to you, this is the nitty-gritty of the procedure. First of all, the patient is a very severely brain-injured patient, but not a brain death, okay? Which means that, let's say, the patient may have gag reflex or brainstem reflex or still moving about, you know. Minimally conscious patient. Actually, the Pittsburgh Protocol, before they instituted the protocol, they had 4 cases, one of which is actually a paraplegic person, a kind of Christopher Reeves type of person, you know, conscious but completely paralyzed arm and leg and everything. That kind of person has high spinal cord injury. The other 3 patients, one were severely comatose but not so deeply comatose as to fulfill the criteria of brain death. And so it is estimated that these people, yeah, they may die if you remove the ventilator and other kind of life support. They may die within 30 minutes, 60 minutes. The limit is 60 minutes, and I explain to you the reason why. Okay, so now it requires 2 consent. The first thing is do not resuscitate. The second consent is a consent for organ donation. The do not resuscitate is actually a kind of consent that rely on patient's autonomy. Yeah, I do not want to be resuscitated. Right, so now after the 2 consents been given, the patient is taken to the operating room. There, the patient is going to be weaned very rapidly from the life support, from the ventilator. It's like to die from suffocation. It is not pleasant. It's painful. And so, in order to help the patient not to suffer, give a large dose of narcotics, yeah, to relieve, prevent discomfort. And now, you have, you know, whenever I use the word anti-mortem or post-mortem, please understand it's like quote on quote, all right? Yeah. So as part of the anti-mortem procedure, cannulate the femoral artery, the femoral vein, okay? Because this is going to be necessary for injecting in preservative fluids and cooling of the organs as soon as the patient is declared dead. Next thing. So now you observe the patient, and there is a transducer that is connected to the artery here, okay? And see whether there's pulse. And if there's no, the minute there's no pulse, mark the clock, and wait for 2 minutes. Right at the 2-minute mark, the patient is declared dead, And as soon as the patient is declared dead, you go ahead with organ removal, which means sternotomy, skin incision, from the top to the bottom there. It's that no-touch period is called the death watch. And the Pittsburgh protocol is the 2 minutes. The Institute of Medicine protocol recommending 5 minutes. All right, so it varies anywhere from 2 to 5 minutes. Next is post-mortem procedure. Now, again, post-mortem, quote unquote. So you have another protocol we call the Michigan protocol, in which, remember where I told you that you have that femoral artery and femoral vein cannulation? That's when you use that for extracorporeal membrane oxygenation, ECMO. After there's no pulse, as soon as there's no pulse, that means no heartbeat, then you connect the patient to a system that is equivalent to a cardiopulmonary bypass system that you use for open heart surgery. Okay, it's called ECMO, to restore the flow of warm oxygenated blood during the interval before death, as soon as and procurement, organ procurement, and that may be like a few seconds, few minutes. In about 25% of the cases, the potential donor, after you wean them off the life support, they still live beyond 1 hour. Well, by that time, I, as a surgeon, I would say, no, I will cancel the transplant, the organ removal surgery, because the organ would not be good anymore. Because what happened is, as soon as you wean the patient from life support, the patient would be in a rapid dying process. During the dying process, there is a decrease in supply of oxygen to all of the organs. So there is an ischemic injury. And any kind of ischemia that happened prior to death, it would affect the organ transplantation. It's the main thing, the reason why we need as fresh as possible organ is because during the dying process, you have ischemic injury, and as soon as death occurs, there's no blood flow, the ischemic injury just increase rapidly. So the long and the short is, after true death, this is the reason why after true death, the organs are not good. Right? The kind of organs that can sustain ischemic injury for quite a long while would be like the kidney, right? But like the heart, the lung, the liver, no, it's within minutes. So what is the justification for the controlled cardiac circulatory death? Believe it or not, the controlled cardiac circulatory death is actually built on the brain death paradigm. And in order to understand this, you have to get into the heart and mind of the brain death proponents, who the guru is Bernard, James Bernard. He's also the CCCD guru. Okay? So in 1981, when Bernard proposed the rationale to defend the Harvard criteria, he proposed the doctrine of the supremacy of the brain as the somatic integrator of the body, meaning the brain is the boss of the body. Just a word, tomorrow. Today I speak as a physician. I wear a doctor's hat. Tomorrow morning, I wear the philosopher's hat. Tomorrow afternoon, I wear the hat of the moral theologian. And I would really ask you to read beforehand the handouts of tomorrow morning's lecture, because it's extremely complicated and extremely difficult. So, in order to understand this part, today I just kind of alluded to it. So, the brain is the boss of the body because the brain is necessary for the functioning of the organism as a whole. You as a person, you are an organism as a whole from the standpoint of biophilosophy. So the brain integrates, generates, interrelates, controls complex body's activities. Therefore, if it is the boss, it controls everything. The idea is that if this somatic integrator disappears, then there's no life. Hence, the loss of all brain functions is the sole criterion of death. Or to say it differently, is to say all death is brain death. If all death is brain death, then how do you test it? Well, you know, this is again from Bernard. You can see there, okay? This urinary death standard can be tested in one of two ways. If the patient is connected to the ventilator, you do the brain death testing, and I presume you have heard about that, you know, the four or five clinical criteria of brain death. If the person is not supported by any artificial ventilation, then you use the quote-unquote cardiorespiratory standard, all right? And then the other argument that they have to say, they said that, well, you know, the irreversibility of circulatory and respiratory functions are adequate tests of death only because they lead to brain death. This is the argument of the CCCD BD proponents. Yeah? I just told you already, all death is brain death. And guess who is saying that? Bartrow, a member of the Pontifical of the working group, 2006 working group of the Pontifical Academy of Science. And then, you know, this idea that all death is brain death is actually espoused by the WHO. The WHO sponsored this one study in Canada, okay, run by Chemie in 2012, and saying that death occurs when there's a permanent loss of capacity for consciousness and loss of all brainstem function. Okay? This may result from cessation of circulation or catastrophic brain injury. Okay? The idea is this: if you consider death as an exit, then you have two entrances. One exit, two entrances. Oh, by the way, and I was telling you about the, you know, earlier you see 2 to 5 minutes, because one is from the Institute of Medicine proposal, 5 minutes, the other one from Pittsburgh, 2 minutes, and all of the hospitals in America, they can go anywhere between 2 and 5 minutes. Where in Europe, what happened is they want to reproduce a situation, they make sure that the person, the CCCD person, they want to make sure to achieve a situation like brain death. So the death watch is 10 minutes, all right? In these 10 minutes with no circulation, the brain will be dead. The result will be a situation equivalent to brain death. And this is the statement that shows to you that the paradigm of NHBD sits on the top of the BD paradigm. Just to summarize, the two pillars of the CCCD is the patient's autonomy, the consent for withdrawal of life support, and the consent for organ removal. The other thing is there's a presumed irreversibility, the assumption that during these 2 to 5 minutes of no touch, you know, basically no pulse, no heartbeat, it's sufficient to establish the irreversible loss of all cardiac, circulatory, pulmonary function. Now what you see, the main flaw, right here you see there's a red flag, is what this protocol is insisting on is the determination of the exact moment of death. Death comes uninvited. You cannot know the exact moment of death. Tomorrow I will talk to you and explain to you why. And also there's an interval of uncertainty around the moment of death. Very much like the moment of uncertainty surrounding the moment of conception. Ethical problems in CCCD, there are 3 types. First, most serious question, are the CCD donors dead? And this whole question hinges on the irreversibility of cardiac function. The other question is the pre-mortem, ante-mortem use of heparin and phentolamine, okay, via the femoral artery cannulation. The next one is the post-mortem intervention, the ECMO after the declaration of death. Now, irreversibility, you have 2 senses of irreversibility. Strong sense of irreversibility means it's absolutely irreversible. It was irreversible yesterday, today, and tomorrow, in the future, for all time. No scientific measure can reverse anything. Well, in medicine, we're not talking about that kind of irreversibility. We have what we call a weak sense of irreversibility. That which is irreversible yesterday can be reversible today because we have the technology. It's contingent on our scientific knowledge acknowledged medical terminology. It's contingent, obviously, if in Timbuktu, something may be irreversible, but here in Rome it will be reversible because we have the technology. So, first question, are the CCCD donors dead? Meaning, does the time window of 2 to 5 minutes meet the weak sense of irreversibility? Okay, that question comes down to what is the time window for the cardiac auto-resuscitation? Meaning, okay, the heart stopped, but you know, does the heart still have the capacity to return and beat? Can it come back on its own? That's number one. Or can it come back and you just kind of give it a push, a jump start? Yeah? So in short, the question is cardiac circulatory function reversible after 2 to 5 minutes? Now what happened was, remember I told you, the Pittsburgh protocol was not preceded by any validation studies. There was absolutely no studies regarding this issue. Unfortunately, and this is written by the Institute of Medicine. Anyway, I read the code for you. Unfortunately, no scientific studies allow a definite conclusion on how long this interval might be. Protocols and practices in the United States and other countries vary significantly in defining this interval. And this reflects the lack of scientific certainty. The shorter the interval between cessation of circulation and the termination of death, extremely problematic to ensure irreversibility. So the IOM say intervals such as 2 minutes are not supported by any experimental data on the probability of auto-resuscitation and are too short to support a determination of brain death due to circulatory arrest. What it boils down to is that 2 minutes is not enough to even establish brain death. Now remember, up until now, you know, maybe you have heard the whole day, is that the proponent of brain death said brain death is death simpliciter. Yeah? So you go with that hypothesis that brain death is death puncto. Yeah? But now the IOM said, here, you know, this CCCD, we cannot even fulfill the criteria. We cannot even fulfill the possibility the patient get into brain death. And then, you know, Bernard at the very beginning, in 1998, criticized the Pittsburgh protocol. And it said that the biggest problem with the Pittsburgh protocol is that the cessation of heartbeat and breathing is not long enough, okay, because you need to have prolonged cessation of heartbeat and breathing so that it can be sufficient duration for the brain to be diffusely infarcted so that you can achieve a state of brain death. Okay, I keep telling you over and over again that this CCCD paradigm sits on the top of the BD paradigm. The conclusion here, at the time of the organs are being procured in the Pittsburgh protocol, death has not yet occurred. According to the data of resuscitation and literature, the cardiac function can be restored easily in patients who have a systole for 10 to 15 minutes. Any of us who are medical doctors here, we have done CPR on patients, and normally we run a CPR for 30 minutes because we have to give the patient the benefit of the doubt. That the heart would beat again after receiving all of these stimuli. Yeah? And then you also have the Lazarus phenomenon, meaning that what happened is the doctor ran the CPR, all right, and it seemed like nothing happened. Well, within some minutes, suddenly the heart come back. Okay, then the heart can come back anywhere from second to 33 minutes after this CPR. Now, obviously, you know, the Lazarus phenomenon is not that frequent. But in science, when you make a theory, scientific theory, you only need one case to prove your theory to be incorrect. Yeah? Tomorrow I talk about scientific realism. Okay? And what happened is, the reality is out there, whatever theory you make, that is in your mind, has to match the reality out there. Yeah? Veritas adequatio res intellectus. So now, remember, I told you a little bit earlier about the Busek in 2008. What happened? At the Denver Children's Hospital, they had 3 cases, right? And up until now, up until 2008, it is implicitly understood organ transplant from CCCD would not involve the heart. You can transplant the liver, the kidney, the pancreas, the whatever you want, but you do not transplant the heart. Why? Because the criteria of death is based on cardiac, right? I told you the DCD, donation after cardiac death. If the heart is dead, how can you transplant it? Well, after 3 minutes, the first patient, they got that heart from that patient, they transplanted. Then for the next 2 cases, he shortened it to 75 seconds. And that created a scandal, an uproar. Okay? Then Bernard came to the rescue of Busek and say, actually C does not stand for cardiac. It stands for circulation. So it's okay that the heart is still alive. But you see what happened is, this is what I call mechanistic thinking. The heart acts as if the heart is separate from circulation. Now tomorrow you would learn that no, man is not a bag of parts. Okay? It's holistic, it's not mechanistic. By that tomorrow. So the Busek success basically tells you that the mechanical asystole of the donor's heart is still reversible. So even, here you have Vich, I have a quote from Vich. Vich is a higher brain death supporter. He pointed out, it's impossible to transplant a heart successfully after the so-called irreversible stoppage. Because it's obviously show you that it's not irreversible, okay? It cannot be a dead heart when you can transplant it and then it come back. You can, it fly into against the common sense, right? So the long and the short, there is no firm evidence that the CCCD donor is dead, whether if we try to push them into a brain death situation, well, 2 minutes is not enough to push them into a brain death situation, but for certainly, they're not dead according to like the traditional criteria of the cardiac death, okay? They're certainly not dead at the time of removal. Hence, in the context of CCCD, this entire reversibility rests on the fact that I, as a doctor, say, well, I just cannot help the heart to start again. I cannot do CPR. I cannot give the heart a jump start because I have to respect the patient's autonomy. Respect for autonomy is the stand-in cause for irreversibility. And then, I showed you a little bit earlier, 1998, Bernard was against the CCCD. Well, within 8 years, he switch camp. And this is his justification, okay? Enacting successful public policies on issues of life and death may require compromises on certain biological facts as they facilitate a socially desirable goal. DCD does violate the death donor rule. The death donor rule means that you can only obtain organs after the person is dead. All right? It is not a rule written anywhere. It's an implicit rule. Yeah? It comprises a justified exception. So DCD is an exception because if the DCD patient is not dead at 5 minutes of asystole, the patient is going to die anyway, incipiently, unequivocally dying, and will certainly be dead within minutes. But a person who's dying is still alive. So what it means, this whole discourse of Bernard just means that in the name of society's best interest and for the good of organ transplantation, we can put aside scientific truth, okay? And we can alter the criteria for the determination of death. And all of this, we do it in the name of respect for patients' autonomy. All right, so now we have a slippery slope. I was telling you a little bit earlier that CCCD patients are severely brain injured patients. They're not brain dead. But what happened is in the IOM allow for a larger category of patients. So now we can have people who can be like a Christopher Reeve's case, paraplegic, but they say, well, my quality of life is so poor. So basically, anybody who thinks that their quality of life is so poor, for whatever reason, okay, physical, psychological, they can come and say, look, I want to have a DNR and I want to have organ, to give my organ away, right? So the case example that I give is from this, okay, there was a 28-year-old man, high spinal cord injury, right? He was quadriplegic, he's ventilator dependent, and as soon as he heard about his diagnosis and he know that he's going to be like that for the rest of his life, he said, look, I don't want to live anymore, okay, give me a DNR, take off the ventilator support, and I want to give my organ. His family were very much against it, okay? His doctor tried to convince him otherwise, but he said, no, 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 you have to respect my autonomy. And so finally, the hospital and the medical doctor yield, right? All right, so the next ethical issue, pre-mortem medical intervention. For the sake of preserving the organs, we give the patients before, while the pulse is still going on, the heart is still beating, okay? This is why we call it antemortem. We give the patients heparin because it anticoagulates the blood, all right? And this is to prevent the formation of microscopic blood clots, because as soon as the blood stops, you get formation of teeny clots, and that would not be good for the organs, all right? And you also give phentolamine. Phentolamine is a vasodilator. It helps the perfusion. But when you have a vasodilator, then you can precipitate hypotension. You can cause the blood pressure to just drop like this. Now, in a patient who have, brain injury, and you create hypotension, you basically decrease the blood flow to their head, right? So you can precipitate them into, you're harming them, all right? Fine. All right, so now justification for medical intervention. Just a background for you to know who Du Bois is. Du Bois is a Catholic ethicist, yeah? He's a brain death supporter. He's also a CCCD supporter, yeah? And he defends the whole protocol of CCCD using the principle of double effect. But his principle of double effect here is a kind of modified, and he used it specifically to justify the pre-mortem interventions. Well, he said the risk of heparin has been exaggerated. Well, let's see whether it's going to be exaggerated or not. Well, he actually didn't look at the large international study in which people who have ischemic stroke, and then you give them heparin, and many of them, on the top of the ischemic stroke, now develop a hemorrhagic stroke. Yeah? So heparin does have a negative effect, especially on brain-injured patients. All right? So another reason they say, well, the intent is actually not to harm the donor, is to ensure organ viability for the recipient. Now, in the principle of double effect, it's for one person, it's not for two people. I don't have time to go into the PDE, unfortunately, all right? And he said that the risk of hemorrhage is merely foreseen but unintended. Well, this is question mark. But here, the next one here, this is really the problematic. Since the patient has withdrawn life support and is in the process of dying, the good at stake is proportional to any risk. So the whole principle of double effect, once again, rests on respect for patient's autonomy. Okay? It's really not a true PDE. Post-mortem interventions. I'll get into a little bit more hairy area here. After the time window, 2 to 5 minutes, okay, or maybe as short as 75 seconds, you are declared dead. But if I want to harvest your lung, I re-intubate you and hook you back to the ventilator in order to aerate the lung, to keep the lung viable. Yeah? And for the rest of the organ, we can use, back in the old days, remember the arteriovenous cannulation, you infuse right away at the time when you call the patient dead, you infuse this kind of a very cool perfusate. It's essentially a preservative to help the organ to be preserved, and you also have the cool temperature in order to decrease the metabolic activity of the organ. But that was the old way. Now what happened is, I think it was about 2000, I can't remember what year anymore, Michigan protocol came out with the idea of using ECMO. Oh yeah, it's in the 2000, right. So what is this ECMO? The same procedure has been applied to patients with cardiac arrest. The patient who cardiac arrest that do not respond to regular CPR. So what happens is you connect them to what is the equivalent of a cardiac bypass machine that we use in open heart surgery, okay? So the blood running out outside in this machine, it gets oxygenated and come back to the body. Now, now in these patients, these are not donors, these are just a cardiac people who have a heart attack, right? And they find out that when they use ECMO, these patients with heart attack, they have a better recovery in terms of their heart function, but especially they do not have neurological deficits. Okay, now you know what, a lot of people who have a heart attack, even if they recover, they may have some sort of neurological deficit, because what happens is during the time of heart attack, you know, especially if you have a serious heart attack, you have a decreased blood flow to the brain, okay, and part of the brain just kind of like die, yeah. So this ECMO prevent neurological sequelae. So happen. If you put the ECMO in somebody that you just declare dead after 2 to 5 minutes, wouldn't that restore the function of the brain? Wouldn't that restore the function of the heart? That is really problematic. What you gonna do? Put yourself into the mind, the heart and mind of the authors of the CCCD protocol. I want to get organ, but I do not want to reverse the death. You know, this is why I was just telling you, all right? How do you circumvent this problem? You circumvent this problem by using a thoracic aortic balloon that you introduce via the arterial femoral cannulation that you had there, and you introduce it into the abdominal aorta. Okay, you position it right at the level of the diaphragm. So as soon as you connect the patients to the ECMO machine, boop, you inflate this balloon, and what happens is you prevent the blood to go to the heart, and you prevent the blood to go to the brain. But the oxygenated blood would still go into the kidney, so you can get the kidney, you still get the liver, still get the lung, whatever you want. Now, this balloon catheter is inserted before the declaration of death, ante-mortem. Then the balloon is inflated immediately as you declare death, followed by a perfusion via ECMO, okay? And you know that anything that is blocked, rostral, okay, blocked by the balloon, you recognize it because the patient's, you know, the head and the chest would become kind of blue, yeah? But remember, initially I said that we don't want to use CCCD for heart transplant, but now we want to use CCCD for heart transplant. We just don't have enough heart. We're going to have to get heart from the CCCD. So how are we going to do this? Well, we're not going to inflate the balloon. We put a clamp right across the aortic arch to prevent the blood flow to the brain. That's all. And we can still have the heart, and we can get the heart. And right now, for many, many years, there has been kind of like, people are very reluctant to get heart from the CCCD. But recently, it has started taking off. Now, the use of the ACMO obviously bring back into focus, are CCCD donors dead? Because if they're dead, then there's no need for the occluding balloon. The fact that you use the occluding balloon means that you are pretty sure that they are not dead. Because I told you already, this ECMO can reverse cardiorespiratory function, can reverse brain functions, all right? That basically means CCD patient's not dead. So, by either putting the clamp across the thoracic aorta in order to push the patient into a brain death situation, or worse, by inflating the balloon, you basically prevent blood flow to the heart and to the brain in order to keep the other organs fresh, and in that way, actually you kill the patient. And it is here that you see the very, very dark side of organ transplantation. I'm not accusing it. It, by its own actions, let's say, condemn itself, okay? So the conclusion, CCCD is very close cousin of euthanasia, because at the last analysis, the only justification for its practice is the principle of respect for autonomy. The autonomy in giving consent to or do not resuscitate it, and the consent to donate organ. Now, the do not resuscitate it, yeah? What happened is when a patient asks me to do not resuscitate it, I will not resuscitate, and I just let that person to die naturally. But you see here, the do not resuscitate is not to allow the person to die naturally whatsoever. All right, right at 2 minutes, right at 5 minutes, I cut you up. All right? So therefore, CCCD is actually a veiled form of euthanasia. It is the immediate precursors of the overt practice of organ donation after euthanasia. And right now, organ donation, euthanasia is being done in the Netherlands and in Belgium, and it's accepted by the Eurotransplant, I believe, since about 2008 or so. And I think that's the end of the talk.